Swayam Prabha. Digital India. Educated India.
Hello, I'm Dr. Medora D'Souza Dias, Assistant Professor at the Goa Medical College and Hospital, Bambolim, Goa, and today I'm going to take for you a lecture on clinical anatomy, KLUMPKEâ S paralysis. Our objectives for today's lecture: at the end of a lecture, a student should be able to define KLUMPKEâ S paralysis, understand the anatomical basis of KLUMPKEâ S paralysis, and correlate anatomical knowledge with a given clinical case. We are breaking up our lecture today into a general outline of 5 segments. Segment 1 is a case study. Segment 2 will feature gross anatomy of the brachial plexus. In segment 3, we will talk about clinical features of KLUMPKEâ S paralysis. In segment 4, we will discuss the case, and segment 5, we will summarize today's lecture. Augusta Desjardins KLUMPKE in 1885 named a neuropathy involving the lower brachial plexus, named as KLUMPKEâ S paralysis. She was a 19th century French physician and who was very dominant in her role at that time. Let's start with our segment 1 being the case study. So we have a 30-year-old man gives a history of falling over a cliff on a picnic, and he caught hold of a branch of a tree with his right upper limb in order to stop his fall. He comes to the OPD presenting a month later with inability to use the muscles of his hand in order to grasp any object. This is what his hand looked like on physical examination. A deformity was seen of his upper limb. The muscles involved in this deformity were the intrinsic muscles of the hand, including flexors of the hand and flexors of the digits. The signs and symptoms include a true claw hand, as can be seen in this picture, and also Horner syndrome. Let's start with our second segment, wherein we'll talk about the gross anatomy of the brachial plexus. What is the brachial plexus? You can see in this picture here, it's comprised of a major nerve network which innervates the muscles, joints and the skin of the upper limb. It begins in the neck from the cervical and upper first thoracic nerve rami and extends into the axilla. Let's look at how this brachial plexus takes formation. Now this is very important because you need to understand the root values of the nerves involved in KLUMPKEâ S paralysis. So let's start with the roots. Right at the top of the figure, the formation of the brachial plexus is by the ventral primary rami of the 5th cervical, 6th, 7th, 8th and T1. So that means the lower cervical anterior primary rami as well as the first thoracic go to form this brachial plexus. Now you may have heard about a prefixed and postfixed brachial plexus. It's not complicated, it's very simple to understand. Prefixed means that C4 also takes part in formation of the brachial plexus. In that case, T1 may have a very less contribution. If you say postfix, that would mean that C5 has very little contribution and instead T2 will also contribute. Now these roots join up to form trunks of the brachial plexus. The C5 and C6 join to form the upper trunk. C7 doesn't join anything but it itself forms the middle trunk, and C8 and T1 can be seen to form the lower trunk. These trunks, upper, middle and lower, are named in accordance with their position, superior to inferior. Now, each of the trunks will further divide into an anterior division and a posterior division. Now, that means each trunk, upper trunk will have anterior-posterior division, middle trunk will have anterior-posterior division, and the lower trunk will also have an anterior-posterior division. Now, these divisions will join up to form the cords. Let's see how that takes place. The posterior divisions of all three trunks are going to form the posterior cord, and the other anterior divisions will go to form the lateral cord and medial cord. How are these cords named? They are named in relation to their relation to the axillary artery. That means the lateral cord lies lateral to the axillary artery, the medial cord lies medial to the axillary artery, and the posterior cord lies posterior to the axillary artery, all of them being contents of the axilla. I'm sure you remember your lecture on axilla, so you'll somewhat link it to that lecture of yours. Let's take a further look at formation and branches of the brachial plexus. So this is what I already told you. C5, C6, C7, C8 and T1 are the anterior primary rami that form the brachial plexus. C5 and C6 join to form the upper trunk, C7 forms the middle trunk, and C8 and T1 join to form the lower trunk. I also told you that each trunk divides into anterior and posterior divisions. So, the upper trunk is dividing into an anterior and a posterior division. The middle trunk also has anterior and posterior divisions, and the lower trunk has anterior and posterior divisions. So, now you see that all three posterior divisions join to form the posterior cord, whereas the first two anterior divisions go to form the lateral cord, and the inferior trunk's anterior division goes alone to form the medial cord. Now, each part of the brachial plexus has got branches. For example, here we are saying that the branches that come from roots. So, which are the branches that come from roots? You can see here, C5 gives off the dorsal scapular nerve, and C5, C6 and T1 give off a long nerve which is called long thoracic nerve. From the trunks again there are two nerves, the suprascapular and nerve to subclavius. Let's see where they are. They are from the upper trunk. So, the suprascapular nerve and the nerve to subclavius. So, these nerves will have root value of C5 and C6. Okay, dorsal scapular will be C5 and long thoracic will be C5, C6 and C7. So, that's how you understand root values of different nerves. Now, let's look at the next slide showing us branches from the cords. We're going to do one cord at a time. So, we start with the lateral cord. So, this is the lateral cord. It gives off the lateral pectoral nerve which goes to supply the pectoral muscles, the muscular cutaneous nerve which supplies the biceps, the coracobrachialis, and also it has cutaneous nerve supply. Then it gives off a lateral root to the median nerve. So, these are branches of the lateral cord. Next, we look at branches from the medial cord. So, this is the medial cord. It gives off medial pectoral nerve, also supplying pectoral muscles, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and a medial root for the median nerve. And a very important branch is the continuation as ulnar nerve. I think median nerve, ulnar nerve, these are familiar nerves. They go to supply the important muscles of the forearm and hand, and they also have cutaneous supply. Now, the posterior cord. So, the posterior cord is a large cord. It's getting contributions from all the nerve root values, and it gives off a lot of branches. So the ones here highlighted in a red asterisk, these are the suprascapular nerves, superior subscapular and the inferior subscapular nerves. There's a long nerve here, this is the thoracodorsal nerve, and also gives off the axillary nerve, which is supplying the deltoid muscle and the shoulder joint, and it gives off the large radial nerve which goes to supply the extensor compartment of arm as well as the extensor compartment of forearm. So we have completed branches of the entire brachial plexus. A special mention about the inferior trunk of the brachial plexus. Now we are interested in this trunk because this is the trunk involved in Klumpke's paralysis. So it has important relations to the first rib. Can you see this first rib here? Okay. And you can see the origin of T1. So T1 has to arch over the first rib. That means that lower trunk is related to the superior surface of this first rib. And here it lies related to the subclavian and the vertebral arteries and also the pleura of the apex of the right lung. And this is where it can get interfered with, it can get compressed between these vessels, okay, and sometimes compression of the lower trunk of the brachial plexus can look like a Klumpke's paralysis. Let's start with segment 3. So these are clinical features of Klumpke's paralysis. What is Klumpke's paralysis? It is an injury to the lower trunk of the brachial plexus. That means it involves C8 and T1 nerves, and sometimes even C7 nerve roots are involved. What is the cause or what is the etiology of this Klumpke's paralysis? So basically, it is a hyperextension of a hyperabduction of the shoulder joint. For example, a person in our case series falls off a cliff and then he tries to prevent his fall or break his fall by clutching any object. In this case, you see, he's clutching a branch of a tree to stop his fall, and his shoulder is getting abducted excessively from the trunk. So this is a traction injury to the anterior nerve rami because of excessive overhead abduction of the arm. Where? At the shoulder joint. So it kinds of pulls off the nerves by traction from the origin of the spinal cord. You can also have this kind of Klumpke's paralysis injury on a fall with outstretched arm. So he falls with his arm outstretched, causing this hyperabduction or excessive overhead abduction. Or another example could be this: a factory worker working in a machinery where his arm gets pulled into the rollers of the machinery. So that will also be a similar type of injury. Another example is here. Can you see this? So it's a large baby, difficult labor, and there's a hand presentation. So when the doctor is trying to deliver this baby and pulling the hand, there is again hyperabduction or overhead abduction of the right arm at the shoulder joint. Even if it's a breech presentation, sometimes the shoulder has not delivered, the breech is being delivered. So again the arm can get extended and it can be involved in a Klumpke's paralysis. Presence of a cervical rib, as I already explained to you, anything that makes T1 arch over even more. So a cervical rib is a rib present on C7 vertebra and it makes C8 arch even higher and undergo traction injury. Then we have listed here malignant metastasis from the lungs in the lower deep cervical lymph nodes can also compress these lower nerve roots of the brachial plexus. So let's look at clinical features of Klumpke's paralysis. So we see here the true claw hand. Why are we calling it the true claw hand? Because there is another type of claw hand called the ulnar claw hand, and that's a different etiology and that's a different type of claw hand. Now what is the injury here? So avulsion of C8 and T1 roots of the spinal nerves from the spinal cord. So they basically separate from the spinal cord partially or totally they are getting pulled off, that's the injury, traction injury. It's called avulsion. What is affected? The flexors of the wrist, the flexors of the fingers, meaning the metacarpophalangeal joints, are paralyzed. What do you get? A true or a complete claw hand. Why we say complete? Because all the digits are affected. So it's called a true or complete claw hand. So the complete claw hand deformity. What is the defect? Hyperextension at the metacarpophalangeal joints and flexion at the interphalangeal joints. So there are two interphalangeal joints, the proximal interphalangeal and the distal interphalangeal. So what is the deformity you get in true claw hand? Hyperextension of the metacarpophalangeal joints and flexion of the interphalangeal joints, both the interphalangeal joints of the digits. Which are the muscles that are paralyzed? So the ulnar flexors of the wrist are paralyzed, the ulnar flexors of the fingers with the root values C7, C6, C8, intrinsic muscles of the hands like the lumbricals and the interossei, because these fibers run in the median and ulnar nerves both. C8 and T1 root values are present in both the ulnar nerve and the median nerve. So you get a complete claw hand deformity. So the extensor digitorum is functioning because it is supplied by the radial nerve. It's functioning unopposed because the lumbricals and the interossei are paralyzed. So what do you get? Hyperextension of the metacarpophalangeal joints. And flexor digitorum and profundus are unopposed because they are supplied by the other root values. And they are unopposed because lumbricals and interossei are paralyzed. So what will you get? Flexion of both the interphalangeal joints. So this is the reasoning behind the deformity of complete claw hand which you get in Klumpke S paralysis of the lower trunk of the brachial plexus. Besides motor paralysis, you will also get some sensory deficits, like you will get cutaneous anesthesia. So there will be parts having analgesia. It will always be along the inner border of the forearm, a little bit of the arm also, and even of the hand. Now here you are looking at the anterior aspect, and on this side you are looking at the posterior aspect of the same right upper limb. Okay, so it is the ulnar border and it extends on both surfaces on the inner aspect of right upper limb. You will also get vasomotor changes because the sympathetic activity which passes through the T1 fibers to the lower trunk of brachial plexus, so these fibers are also affected. So you will get vasomotor changes, the skin area with the sensory loss, that means the shaded area, it will be warmer because of arteriolar dilatation, and it will be drier because of absence of sweating because there is loss of sympathetic activity. Then you will get trophic changes. Why? Trophic changes come during long standing cases, okay, after several months. You will get paralysis first, then this leads to drying and scaly skin because we said here absence of sweating because there is loss of sympathetic activity. Okay, so then you will get dry, scaly skin, the nails will crack easily and there will be atrophy of the pulp of fingers. So these trophic changes, remember, will not come immediately, but they will take some time. It will be over a period of a few months or so. Whereas the initial changes that you will get are the sensory losses, even the vasomotor changes you will get, and of course the motor paralytic muscles, the true claw hand, these changes will be earlier, whereas trophic changes will always take a few months. Then you also get Horner's syndrome in Klumpke S paralysis. Why? Again, because of the sympathetic activity which is lost. So the sympathetic fibers supplying the head and neck, they leave the spinal cord through T1 and cause Horner's syndrome because they are now paralyzed. So you will get partial ptosis, as you can see here on the right side. There is drooping of the upper eyelid. It droops lower down. So you will see part of the iris is covered by the lid. And then there will be meiosis, which is a constriction of the pupillary aperture, anhidrosis and enophthalmos. Okay. So these are all features of something called the Horner syndrome, and it is due to interference of the sympathetic fibers to head face neck leaving through T1 spinal segment. When you physically examine the patient, so you will see first of all the clawed hand. I already explained to you. What is it? Hyperextension of the metacarpophalangeal joints and flexion of the interphalangeal joints. So T1 is damaged. There is loss of sensation on the medial side of arm as well as C8, medial side of forearm, medial side of hand and the medial 2 digits. That means the ring finger and the little finger. When you do a pinprick test for skin sensory deficits, you will find there's paresthesias and a degree of anesthesia. So that's called a C8 T1 radiculopathy. There's sensory deficits, as I explained to you, on the inner line or the ulnar aspect of the lower arm, forearm as well as hand on both sides, the anterior aspect as well as the posterior aspect. Then you will get paresthesias, which is numbness and tingling, or you will get pain radiating down the inside of the forearm right up to the little finger. It's also called the pinky finger. Okay, so you will get paresthesias, you will get anesthesias, and all this is called a C8T1 radiculopathy. So when you do the pinprick test of skin, you are testing for this radiculopathy. Then you will examine for movements of the muscles. So you are looking for what? You are looking to see whether there is movement or there is a loss of movement. Is there a complete paralysis or is it incomplete paralysis? So you will test the person's ability to perform certain movements, and this will give you the degree of paralysis. So you will ask the person to do an OK sign. You will also check for grip strength. What is complete paralysis? That means no movement can be detected, no movement can be done at all. That means the muscles are completely paralyzed. Most often it is an incomplete type of paralysis where the muscle can move, the muscle will move, the person can move the muscle, can do the movements, but the movements are weak. If you compare them with the normal side, you will find that the affected side has weaker movements. So this is an incomplete type of paralysis. So here you can see in this picture, you are asking the person to grip something, like making a fist and gripping something. But what is he doing? This outline is a normal grip. Can you see the lighter color outline? And the darker color outline superimposed shows you the defective position of the hand in that grip. So he is kind of getting a claw hand when he is trying actually to grip an object because of the complete paralysis of certain muscles like the lumbricals and the interossei. Okay. What is happening is there is hyperextension of his metacarpophalangeal joints and flexion of both interphalangeal joints. So what is the differential diagnosis of Klumpke S paralysis? So one differential diagnosis is a cervical rib. In this picture you can see this is the first rib, thoracic rib, but above it the costal element of C7 vertebra develops into a rib. It may be complete, it may be incomplete, it may be fibrous, it may be osseous, but it is going to cause something that looks like Klumpke S paralysis. Why? Because now the roots of T1 and C8 have to arch over the cervical rib in order to go into the axilla through the cervicoaxillary canal. And so when they arch over, there can be traction on the lower roots, that is C8 and T1. Okay. This is also called the thoracic outlet syndrome because not only are the brachial plexus lower trunk involved, but even the subclavian vessels are involved in compression. So this is the thoracic outlet syndrome. So you have a cervical rib, That means everything has to arch over one more rib. The traction becomes more on the lower trunk of brachial plexus as well as the subclavian vessels. So you'll get nerve related problems, but you'll also get the blood vessels compressed. So pressure due to symptoms caused by the lower trunk of brachial plexus, pain produced down, this paresthesias that I spoke about along the inner aspect of the arm and forearm and hand. You will get wasting of the small muscles of the hand like the lumbricals and the interossei. There will be pressure on the blood vessels also, which can compromise the blood circulation in the upper limb. If you go further, even a fracture of clavicle, if it's a fracture wherein the bony fragments are compressing the structures of the brachial plexus, it could interfere with the lower trunk of the brachial plexus and mimic a Klumpke's paralysis. Or even a lung tumor in the apex of the lung called Pancoast tumor. This can also mimic a Klumpke's paralysis. A cervical disc herniation in a disc here, say C8 and T1, it is going to start compressing the nerve roots and cause something that looks like Klumpke's paralysis. So these are all differential diagnosis of Klumpke's paralysis. Now earlier I spoke to you and said that Klumpke's paralysis causes a complete claw hand. Okay, why? It's called a true claw hand because there's something called ulnar claw hand. So ulnar claw hand is not the claw hand of Klumpke's paralysis. Please remember, okay? So ulnar claw hand is a different type. It's also the incomplete type of claw hand. Here, if you look in this picture, can you see the thumb, index and middle finger are absolutely normal, but the pathology lies in the functioning of the ring finger and the little finger. So what is happening here is, this is because of compression of only the ulnar nerve, okay? So only the ulnar nerve supplies the medialmost part of hand, okay, including the medial parts of the intrinsic muscles of the hand, like the medial two lumbricals and the medial two interossei of both dorsal as well as ventral. So what happens is, for example, when the ulnar nerve is injured, not at the level of the lower root of the brachial plexus, but somewhere lower down, like cubital tunnel syndrome in the cubital fossa, which lies at the level of the elbow joint, little below the elbow joint, okay. So what happens is, only ulnar nerve is involved, so there is hyperextension of metacarpophalangeal joints and flexion of interphalangeal joints only in the 4th and 5th digits, whereas the other 3 digits are absolutely normal. So how will you check for ulnar claw hand? You will get only the medial 2 digits involved, whereas in true claw hand or the claw hand of Klumpke's paralysis, you will get all the 5 digits involved. Please remember this. How do you treat Klumpke's paralysis? So, there is physical and occupational therapy. There are daily exercises. So, this increases the range in motion. It will improve the muscle strength and prevent any joint contractures due to immobility. Then splinting is also used for maintaining proper hand position to prevent a claw-like hand deformity. So they will splint the hand to keep every joint straight and prevent the hyperextension at metacarpophalangeal and flexion at interphalangeal joints. Then massage to stimulate nerves and muscles. Electrical stimulation has also been used. It is tonic pulses which are given by electrical mild currents. It helps to build the muscles up and reduce the pain. Last, of course, is surgical intervention. If everything above doesn't work, there's no improvement with all of the above methods of treatment, maybe you will take 3 to 6 months. Now, after 6 months, if there is still no improvement, then nerve grafting or muscle transfers can be attempted surgically. So, we have discussed the Klumpke's paralysis. Let's proceed now to segment 4 of our clinical case discussion. So, what is your diagnosis? So, our diagnosis in this case is Klumpke's type of paralysis. What is the etiology of Klumpke's paralysis is our second question. So, we have discussed a case of a person falling and trying to clutch at an object to break his fall, causing excessive overhead abduction of the shoulder and avulsion traction injury of the nerve roots of the lower trunk of the brachial plexus. Other causes for Klumpke S paralysis can also be a person whose arm gets into the machinery and gets hyper abducted from his body, or in cases of a neonate or a child that is born, because of pulling of the arm during arm presentation in a cephalic position, or in a breech position is because of the shoulder and arm delivery, there is hyper abduction of the arm at the shoulder joint. Our third question is, what are the clinical findings on examination of a case of Klumpke S paralysis? So, the most important finding was a true claw hand, which is a deformity wherein there is hyperextension at the metacarpophalangeal joints and flexion of the interphalangeal joints of all 5 digits, as well as there are sensory areas, deficits of anesthesias and paresthesias wherever there is C8 and T1 distribution, that is along the ulnar side of the lower arm, the forearm as well as the hand. Horner syndrome also we said is also present because of the sympathetic loss of activity, as the sympathetic fibers of head, face and neck pass through the T1 nerve. Our fourth question, what are the differential diagnoses? So here I presented many differential diagnoses, one being fractured clavicle, the other one being anything that interferes with the arching of the fibers over the first rib like cervical rib, thoracic outlet syndrome. Then we also spoke about the ulnar type of claw hand, which is because of a defective or an injury of the ulnar nerve at the region below the elbow joint. So like it could be a cuboidal tunnel syndrome where only ulnar nerve is affected. So only the medial 2 digits are having hyperextension at the metacarpophalangeal joint and total flexion at the interphalangeal joints, but only the medial 2 digits. The other 3 digits, thumb, index and middle, are unaffected. So with that, I think we complete our differential diagnosis, and let's do a summary of what we have studied today. So I've spoken to you about Klumpke S paralysis. It is nothing but an injury to the lower trunk of the brachial plexus, which is usually formed by the 8th cervical and the 1st thoracic anterior rama of the spinal nerves. Sometimes even C7 nerve root can be involved in this injury. So it's a traction injury. It is caused by excessive overhead abduction of the arm and even an extended arm in a breech or in a large baby delivery. What are the clinical features? First, complete claw hand deformity, cutaneous anesthesias along inner aspect of the arm, lower arm, forearm and hand, analgesia along that region of hand and forearm, vasomotor changes we spoke about, long-term trophic changes after some months, and of course the Horner syndrome. On examination, there is the pinprick test of skin. There are the testing for muscle movements like doing the OK sign and performing the hand grip. So there you see the defect of the claw hand formation. And treatment we spoke about, milder forms of treatment like physical and occupational therapy, some exercises, splinting, massaging, electrical stimulation. And if this doesn't work for around 3 to 6 months time and there is no improvement, then only will a surgical intervention be considered, like maybe muscle grafting or nerve grafting procedures. And with this, we complete our topic for today. Thank you.